Welcome everyone to our webinar titled as COVID Vaccinations, Efficacy, Options, and Special Considerations for Chronic Illness. So our CEO and President, Emily Taylor, is on the weather today. So on behalf of her, I believe I want to share our gratitude for all your interest and support and attendance for this webinar. And we really appreciate the opportunity to work with you. So today, we're excited to welcome our distinguished physician, Dr. Melanie Hoppers, who is a medical provider from Bateman Horne Center, and Jessica Malaty Rivera, who is a chair for the Committee of Scientific and Medical Advisors for Vaccinate Your Family. As an introduction for Dr. Melanie Hoppers, she's a practicing physician, board certified in internal medicine and trained in pediatrics, and also a medical provider at Bateman Horne Center. Beyond her clinical practice, Dr. Hoppers is actively involved in numerous clinical research projects, furthering medical knowledge and striving to improve patient outcomes. Her contributions to ongoing research initiatives underscore her dedication to advancing the field of medicine. She is committed to making meaningful contributions to healthcare and improving the lives of those she serves through her clinical work, research endeavors, and leadership role. And another speaker for today, Jessica Malaty Rivera, is an infectious disease epidemiologist and science communicator. She earned her Master of Science in Emerging Infectious Diseases from the Georgetown School of Medicine and has dedicated the last 15 years of her career to disease surveillance research, public health policy, and vaccine advocacy. Her specialty is in translating complex scientific concepts into impactful, judgment-free, and accessible information for a diverse audience. She's currently the science communication lead for the COVID tracking project at the Atlantic. Her researchers with the COVID-19 Dispersed Volunteer Research Network, a research affiliate at Boston Children's Hospital Innovation and Digital Health Accelerator, and an expert contributor for NBC Bay Area and CNN. Now, I would have the pleasure to invite our speaker to start to give some of their own remarks about their personal experience and their view on this general topic before we move on to the Q&A session of our webinar today. So Dr. Hopper, would you mind giving us some remarks to comment about your experience and your view on this general topic?
Sure, I'd be happy to. So again, I'm internal medicine, pediatrics, and I became introduced to ME/CFS about 9 years ago when my daughter became ill. I was one of those physicians who didn't know much about it at all prior to that. We were not trained on it in medical school, and so I got a quick education, not quick, but I got an education on this illness, and soon found out how complex it was and how it's not so uncommon. And so then I began to see patients with ME/CFS, chronic complex illnesses. And because of my daughter, I really do understand how what a big deal a vaccine is for people. And, you know, it's easy for us to say, hey, go get a vaccine. It's good for you. We all know that as patients with ME/CFS, have a different reaction to things. So I can understand concern and understand questions. And I just want you to know that I understand some of the feelings that go into this. So just kind of want you to know that I have the same thoughts that you may have had. And hopefully the things that I've looked at and researched and read about will give you some insight into the vaccines and help you feel good about them.
Thank you very much. Ms. Rivera, would you mind giving some remark?
Yes, happily. So I'll start by saying that I am not a medical provider. I am a public health scientist. So I'm coming at this from more of a epidemiological research perspective, and I find the topic extremely fascinating because somebody who has spent most of my career studying emerging infectious outbreaks and ways in which to prevent and control them. Understanding the way in which a vaccine can reduce harm is probably the core of my research, and understanding the reasons in which people trust a vaccine or don't trust it is also part of my current research and understanding the information ecosystem that we live in, especially digitally. I know personally a number of folks who are suffering with ME/CFS, and so because of that, I have paid close attention to the emerging research from a public health perspective and will continue to, because I find this to be probably one of the most important topics when it comes to our health as a nation in this next decade or two, because COVID is not quite behind us. And because of that, I think this will be something that we'll have to spend a lot of time and resources from both a clinical and public health perspective and research.
Thank you. And we appreciate the remarks. And also, our audience have pre-submitted questions. So I'm gonna ask my colleague to transition to some slide deck where we have the pre-submitted question listed. And before we start with those questions, I do want to restate some of the main topics for our webinar today. There are four major topics we're having in mind. The first one is the effectiveness of COVID vaccination in preventing long COVID and other long-term symptoms. The second one is an overview of the different types of COVID vaccine currently available. The third one is insights into how vaccine manufacturers address the special needs of individuals with chronic illnesses during vaccine development. The fourth one is an advice on how people with ME/CFS, long COVID, and other infection-associated chronic conditions can make informed decisions about COVID vaccination. So with that, my colleague has projected on a pre-submitted question on the screen. So the first one that we can see right now is, does the COVID vaccine prevent long COVID? So I will open this question to our panelists to answer.
So this study was actually recently discussed on an ECHO lecture, and I believe it came out in April. And it was really interesting because of how big it was. There were 20 million participants. And what it showed, the gist of it was that what they did is they went back retrospectively and looked at data, and they used 3 different countries. It was Estonia, Italy, and I think it was Spain. And it varied, but it ran from 29% to 52% reduction in the incidence of long COVID in patients that were vaccinated. There was a tiny difference in that Pfizer was a little bit more effective than Moderna, and Novavax was not included in the study, but it was postulated that it would have the similar results. So that was really good information, and to me, very encouraging.
And thank you. And Ms. Rivera, do you have anything to add?
I will say that I too was encouraged and noted the significant size as one of the many kind of benefits of a publication like this. We've been speculating about this benefit for quite a while in the possibility of reducing harm or reducing risk. And so I shared in the chat the link to read more about this, but 30 to 50% is not a small number. And so I am encouraged by that trend. And I think we'll probably see more large scale and long-term studies to understand that relationship between COVID vaccination and reduced risk for long COVID.
Thank you very much. I'm going to ask my colleague to move on to a second pre-submitted questions. And how effective are the vaccines? Maybe this time I'll invite Ms. Rivera to comment first, and then followed by Dr. Hoppers' comment.
Yeah, so this is an interesting question because, a lot of times people mix up the words. And as an epidemiologist, where I'm trying to understand the difference between types of, in the meanings of different things, even epidemiological terms, we study vaccine efficacy in the context of clinical trials, and we study vaccine effectiveness post-trials in the real world using real world data. And one of the complicating factors of living in the midst of an ongoing pandemic and an ongoing outbreak of a disease that is now quite endemic in our population is understanding the true effectiveness is very difficult in the context of a hybrid immunity situation where you have most every single person on the planet who's had some sort of previous infection with the virus compounded with a possible vaccine-induced immune response. It's sometimes difficult to understand what true effectiveness might mean. That said, I think we've also in the communication of vaccine effectiveness have missed part of the meaning of why we vaccinate. Primarily, if you look back at the endpoints of those vaccine studies, what we were trying to do was reduce hospitalization and reduce death. And if those are our endpoints today, even in understanding effectiveness, they are still quite effective. The stats you see on the slide here demonstrate that they are still extremely valuable in especially high-risk populations, keeping them out of hospitals and keeping them alive. The concept of breakthrough infections is something that still keeps me up at night because I think breakthrough infections is a bit of a misnomer. Even in the context of flu vaccines, for instance, I mean, we don't tell people that you won't get it if you get vaccinated. We say it will reduce your symptoms and probably reduce severe outcomes. And so I, believe evidence-based, it is still extremely effective based on effectiveness data, but it is a little bit muddier now to discern between those things.
And thank you, Dr. Hoppers, please.
I echo everything you just said. Reading, I did a lot of reading before today, and it is hard. What I used to tell people before COVID, when it was the flu season, I would say, look, we don't know how effective it's going to be yet, right? But I'm trying to prevent you from dying, and I'm trying to prevent you from being in the hospital. And that's where we are again. Same thing applies. And so, yeah, nothing's going to be 100% effective at reducing symptoms or infections. And again, if you get really sick, but you get better, that's still a win. And so yeah, so I pretty much have come to the same conclusion as our flu vaccines.
Thank you very much. I'm going to ask my colleague to move to the next question. So this question is on many of our supporters' mind. Should a patient with ME/CFS pre-medicate with antihistamines before the vaccine? Dr. Hopper, would you mind to kick off the comment?
Sure. So, this is a tough question, and I've looked this up to see what other people were doing. I know what I do, and what I do is there's not a study I'm basing it on. I can't tell you that, there was a research that showed if you have MCAS or you have ME/CFS, you do better if you do this. There's not. I did find, though, which made me feel better. I'm trying to pull it up over here that I'll find it in a second, but one of the allergy groups also is suggesting something similar. And basically a couple things. If you have ME/CFS and you have MCAS, or you have ME/CFS, and as far as you don't have MCAS, at the end of the day, if you're having a bad day, if you're in post-exertional malaise, that is not the day for you to get the vaccine. It's not the day for you to do much of anything, right? I mean, you probably couldn't get the vaccine, but you need to go. And if it's not a good day for you, don't let that be the day that you go. Some people if my patients, if they're going in and they have MCAS, they're probably on H1, H2 blockers. So I might adjust the dose up, just depending, for a day or so before and a day or two after. Vaccines promote inflammation, right? That's what they're doing. They're causing an immune response. And so if you're not in a good place with your ME/CFS or with your MCAS, then that needs to be kind of gotten under control beforehand. The other thing is, if it's possible, rest up until a few days before your vaccination and plan on resting a couple of days after, and that may help mitigate some of those side effects and feelings, or even PIM, because some people can have PIM from something like a vaccine.
Thank you. And then Mr. Rivera, any additional comments?
I'll sit this one out as I'm not a clinical provider.
Thank you. I'm going to ask my colleague to move on to the next slide. This question is, how long am I protected from a new infection after having COVID-19? So I would invite Ms. Rivera to kick off the discussion and then followed by Dr. Hoppers.
Yeah, this is, again, a very difficult question to answer with certainty and precision because, again, it is not, a plug and play where you get a vaccine and you have a certain number of days of protection. Everybody's different. Pre-existing conditions, comorbidities, et cetera, can create different variables that complicate this or make it much less standardized. But typically, we understand that immunity post-vaccination lasts several months. And that it is, typical for folks who might be immunocompromised to have a shorter duration, which is why the recommendation is to have a different cadence of boosters or of updated vaccines. That said, I think because vaccine uptake has been relatively low when we weren't on an annual cadence, you're not seeing as many opportunities to get boosters as there were in the first 3 years of the pandemic, and we've switched to an annual cadence in the hopes of having a higher uptake of the vaccine in the general population. But generally speaking, it lasts several months, and several can be a bit relative. I've heard everywhere from 3 to 9, depending on the person's body. So, Dr. Hoppers, I'd love to hear your takes on this.
I mean, I agree. It's the same thing. One thing I would say is to make sure you stay up to date. The other thing is to, do the other things as well. Wearing your mask, trying to stay, if someone's sick, I keep my distance if at all possible. Especially for if you have ME/CFS and or immunocompromised, and you can, as was mentioned a second ago, get that extra booster if you are immunocompromised. And you don't, I think somebody asked a question about, do you have to have a note? And you do not. You can self-attest if you have an immunocompromising disease that would allow you to get an extra booster.
Thank you. And now I'd like to request my colleague to move to slide number 4, which is a list of COVID vaccines that Dr. Hopper has prepared. So the reason I want to pull out this is this is a question that I often linger on our supporters' mind, which is if we think taking vaccine is a right decision for me, which vaccine should I go with? And I think Dr. Hopper has put in effort to put a list here, and this will be linked to the question as to whether the COVID vaccine can prevent long COVID. So Dr. Hoppers, would you mind going through the 2 major types of vaccines and any difference that you have observed clinically?
Sure. There's the messenger RNA vaccine, which is it's a vaccine that has not been available to us before. It's not necessarily a new technique. They've been working on it. They were actually working on creating a flu vaccine when the COVID pandemic hit, and so they were already sort of primed and ready for this, which is partly why they were able to get it out so quickly. mRNA vaccines are easier to produce, or at least can be done so more quickly, which is one of the reasons why they were developed, was so that in something like a pandemic, as the mutations occur and you need new boosters, this allows us to get them out more, like it's me, but it allows those that produce them to get them out quicker. There's the Moderna, and then there's the Pfizer, and I learned this weekend, it's BioNTech, not BioNTech, but BioNTech. And those are the two messenger RNA vaccines. They're available to people 6 months and older. Neither vaccine contains eggs, latex, gelatin, or preservatives. There's a stabilizer and excipients that help the mRNA get into the cell. That it contains lipids, so it does have polyethylene glycol. So if you're allergic to that, that's what's in Miralax. So if you're allergic to that, you can't take these vaccines, but that's very few people have those allergies. Then there's the protein subunit vaccine, which is a more traditional vaccine, and that's the Novavax. It's available to people that are 12 and older. It contains the protein it's actually kind of interesting. It's produced by moth cells, and it also contains an adjuvant, which comes from tree bark. And so that adjuvant helps you produce a better immune response. And so those are the two types of vaccines. I really, in looking at everything, I can't tell you that I see any, I don't have enough people to tell you, oh, it's so much better if you get this vaccine or that vaccine. And the data really doesn't show that either. What I did see is that some people will suggest doing the primary series and say the messenger RNA, and then do the booster with the Novavax to get a little different, a different immune system or a different immune response. But it really, I don't see that there's data yet to show that that's something that's proven. But that's just some people were suggesting that. Again, there was maybe a slight decrease in events of myocarditis, pericarditis in the Novavax vaccine, but that's a small group of people that have that, and it's a very small incidence. And by the way, it's also more likely for you to get that if you get COVID. So it's not a reason not to get the vaccine. But if you are a male between the ages of 12 and 30, then you may veer toward the Novavax. But again, that's not actually, that's preliminary data, not hard, solid data at this point. It's so hard, it's such a moving target with so many people, and, partial vaccination and, getting the results. It's just really hard to nail down if any one of them is better than the other at this point.
Thank you. And Mr. Rivera, do you have anything else you want to add?
The only thing I would add is perhaps a nod to recent data that was just announced by Moderna about a combination influenza and COVID mRNA vaccine that was they had positive phase 3 data that was just announced, and that they plan to take this to the next level in publication and with the regulatory bodies. This is something we've been hoping for since the beginning of the COVID-19 pandemic in order to kind of reduce the ask, because that is very much the logistical aspect of going and getting a vaccine is very much part of the challenge of reducing overall disease burden. And so to have combination vaccines could really alleviate the steps in that process, especially during flu season. And now we're just calling it respiratory virus season, thinking about the triple threat of COVID, RSV, and influenza. That data is very encouraging to me, and it seems likely that it would possibly be available by the 2025 respiratory virus season, not this year, but the updated vaccines are probably going to be approved very soon by ACIP and CDC.
Thank you. And I'm going to ask my colleague to move to the next slide. So now we have a general overview for the different vaccines. So this is actually a slide I believe the speakers comment a little bit about some comparison between different vaccines. So especially for in the effectiveness in preventing long COVID symptoms. So wonder, Dr. Hoppers, and would you have anything else?
No, I mean, again, it just shows that it is effective. And I think there was a question in the chat I saw about, does the vaccine reduce symptoms in people who have long COVID? So in other words, I think what they're asking is, if you have long COVID and you get the vaccine, will you improve? And I remember a year or two ago, there was a little bit of chatter that, yes, it seemed like it was helping, but since that time, it seems like maybe it's short-lived. But so I can't tell you that there's any hard facts that it will improve long COVID, but on the other hand, if you have long COVID and you get infected again with COVID, there is, each time you get a COVID infection, there's a chance that you can worsen with your ME/CFS or your long COVID. So again, we're back to preventing more harm. And so I do think that, that can be said. And again, I can't tell you that there's hard data that shows that it will decrease your symptoms of long COVID on a permanent basis.
Thank you. And any additional remarks from you, Ms. Rivera?
Yeah, two short comments. One, that, because COVID is still relatively novel in our understanding of its impact in the human population, I think we are going to rely heavily on larger studies, continuing studies, longer term studies to really understand what it means to prevent long COVID or reduce the impact of long COVID on people's bodies. Like Dr. Hoppers said, I think that we have to recognize that reducing harm is one of the primary ways we can understand long COVID too, that each infection holds its own unique opportunity to create complicating long-term effects. And so to prevent those numbers of infections is of utmost importance.
Thank you. And so this concludes our pre-submitted questions so far. And just for the audience to be aware, and just a reminder that to submit a question, please click on Q&A at the bottom of your Zoom screen. And we will look at the popular vote and to determine the priority for the questions, since we want to serve the most part of our audience to answer their questions. And also another thing I want to share with the audience is that SolveME has a real-world data platform called Solve Together. In this platform, we have users who have experienced ME/CFS and long COVID. And our hope is that by collecting real-world data, we can actually provide the basis and foundation for more precise study to help us make the breakthrough in both diagnosis and therapy. So what my colleague projected on the screen is a quick QR code you can scan to review our platform's instruction and join. While I will keep the screen on the on display right now, I will go with the first question that was submitted in real time by our audience. So the question that got very high vote is, in 2021, patient-led data from our community was suggestive that about 10% in our cohort were experiencing setbacks from these COVID vaccines. Does this panel have any insight as to what might be causing these setbacks that have been life-altering for many? In that case, I might invite Dr. Hoppers. Would you start by answering this question, please?
Right. Well, I think what I think is most likely to be going on is patients with ME/CFS or long COVID or ME/CFS caused by long COVID have a dysfunctional immune system. And the vaccine is intended to create a stimulus to your immune system, is doing what it's supposed to do. And I think, unfortunately, in some patients, they have more of a storm instead of just a stimulus and, teaching the body to create the antibodies that it needs to fight long COVID. It goes further. And there's a cascade of inflammation that causes more symptoms. And that kind of harkens back to what can you do to try to, I can't say that here's what you can do, A, B, C, and D, and this is going to keep that from happening. I don't have that. But what I can say is that it's more likely that you'll have less of a response if you are, if your symptoms are controlled, if you try to do what you can to mitigate. Like I said, for some patients, in my practice, and again, I'm not trying to practice medicine on the webinar, And this is, again, just full disclosure, this is not something I'm basing on a study, but in my patients who frequently also have mast cell activation syndrome, I treat with H1, H2 blockers, which someone asked this question, histamine 1 and histamine 2 is what H1 and H2, what I mean by that. When I use that abbreviation, I apologize for not spelling that out earlier, but it's a histamine 1, such as Claritin, Zyrtec, those type of medications, and then H2 is like Pepcid and medicines like that. I use that to help reduce the histamine response that can be triggered by the vaccine. And sometimes that can help with the reaction that patients have.
Thank you. And Ms. Rivera, do you have anything else to add?
The only thing I would add is, again, from an epidemiological perspective, this is data that we are poring over. The VAERS is a resource that is very important to use for this type of understanding. It is also often misused in the attempts to create causal relationships between vaccines and adverse events. That's not to deny adverse events, because they do happen and setbacks do happen. But I think, again, from the space in which I do this research, I think we still have a lot to learn in understanding what exactly is causing these things and ways to reduce them. I anecdotally know folks who experience long COVID and are suffering with these conditions, and anecdotally have shared the same types of setbacks or stories of their own setbacks. So it's very real and requires a lot more research and understanding the relationship between the vaccine and those events.
Thank you. And a second related question that also get popular vote is, with the knowledge that we cannot provide medical device through the webinar, will the panelists have any recommendations, might provide relief or solutions to the cohort setback from these vaccines?
Again, this is a really hard question, and but I'd really want to be helpful and not just avoid the question. But one thing is, for instance, Solve.me has some great resources on their website. The Bateman Horne Center has some great resources. If you can find a primary care provider who can help you utilize those resources and help, you need to, for patients who maybe have more PIM because of their setback, they work on pacing and things like that, which there's resources on the website that can help you with that. I can't advise you on a certain medication or thing like that, because it's so individualized, and I really don't want to put anything out there that would be harmful perhaps to some people versus helpful to others.
Thank you. And Ms. Rivera, anything else you want to add?
I would agree. There are, going to Solve and other groups that are providing public and free resources for folks who are living with long COVID and living with these conditions is probably the best bet. I certainly cannot provide any clinical recommendation to alleviate the burdens of these setbacks.
Thank you. And also from a research standpoint, I want to say that for our real-world data platform, one of the potential is that if we can report which part of the population experience a setback, and then we can match to their demographic features and the individual symptom they previously experienced, then there's a possibility that we might help to identify which group might be at higher risk for such setback. So all that is to say that I think this is the question. I think the field, all the researchers do not have a conclusive answer yet, it seems like. And so we are actually working on such a frontier type of question. So we do hope that pretty soon we would have better sense. But this is in the field of so-called precision medicine. The same vaccine, which might do no harm for the majority of the population, but which may generate some setback for others. So I think the question is, how can we more precisely identify those who are at higher risk and who are not as of high risk? So I will move on to the next questions. Another question that's very popular is, have any of the studies been done specifically in persons with MCAS? I think it's a mast cell activation syndrome.
I did not find anything in regards to MCAS and the COVID vaccine.
And Dr. Rivera, anything else you want to add?
There is one study that I found from 2023 about immunological dysfunction and mast cell activation in long COVID. I'm happy to just drop that in the link. It was, I can't remember which type of study it was. It could have been literature review, but I'll share it.
Thank you. And so in the meantime, a question comes out is, do you consider long COVID to be an immunocompromising disease, or relative to how frequently to get COVID boosters?
Can you repeat that question? I'm sorry.
Yeah, this is the question is, I believe the first part of the question is that whether you consider long COVID to be an immunocompromising disease.
It is dysregulation of the immune system. Mm-hmm. And then what was the second part?
The second part is in the bracket of asking and to further explain that this question is about how relatively it is relative to how frequently to get COVID boosters. I think my reading of this is that if it's immunocompromising, then whether getting COVID boosters will help to boost the immunity.
I see. Yeah.
So that's how the linkage I see here personally. And Ms. Rivera, anything else to add?
I mean, I would agree with Dr. Hoppers in the sense that it is dysregulation of the immune system. What I can't speculate on is it's, if it can give a person a proclivity to other things specifically. But a dysregulated immune system is certainly a weakened position to be in. And so because of that, I think we have to be very tailored in the type of care that person will get, including the recommendations for their vaccine cadence.
Thank you. And another popular question that actually somewhat related to the question we already touched upon is whether there's any data to show whether long COVID symptoms worsen, improve, or stay the same after getting a COVID boosters. So I would invite both Dr. Hopper, if you have any additional comment to help answer this in more granularity, please, you're welcome to answer this.
Yeah, what I found was that initially there may be some improvement, and not to say that no one has improvement ever after that, after a vaccine booster, but it in general is not something we can bank on that, oh, if you get this, you're going to improve with your long COVID symptoms. So again, there's so many outliers, right? That's part of the problem too. When you look at data, it may say very few people, they don't give you exact numbers necessarily. If you go to the CDC website and look at some things, it'll say this is a small, just a few people do this or that. And so there's not necessarily any numbers out there to tell you how many improve. And we don't know, right? Because we aren't collecting data on all these people necessarily. So a lot of it's just anecdotal. And again, going to Solve and doing the registry is very helpful. One of the things I did find, the one thing I did find about ME/CFS and vaccines was on the Solve registry. So that was very helpful. Thank you.
Thank you, Dr. Herbert. Much appreciated. And Ms. Rivera, anything else you want to add?
No, I would agree with Dr. Hoppers on this.
Okay, thank you. And this will be another question that's related to what we discussed earlier, is whether there's any brand of vaccine that would be better or worse for CFS people with CFS in terms of side effects, etc. So I guess we touch upon this, but I want to still give the panelists an opportunity to elaborate a little bit further if there are any additional things you want to add.
I didn't find any compelling data to make me feel like one was going to be better than the other for my patients or for my daughter, and I looked at it carefully. But yeah, I mean, again, there was some talk about doing like a mRNA as your primary series and then doing the Novavax as the booster. But there was nothing compelling that made me feel like one was better than the other. And I haven't seen anything in my clinic that would not be research-based, but anecdotal. I haven't seen any difference with that as well.
And before I invite Ms. Rivera to see what she has any additional comment, there's a related question: is whether do the different types of COVID vaccine, mRNA versus protein-based, impact the likelihood of vaccine side effects or the efficacy of the vaccine? So essentially, the same questions, but within these two questions in mind, Ms. Rivera, do you have anything you want to add?
So I too have not seen any data that would suggest one vaccine is superior to another when it comes to the MECFS question. I also have not seen enough data to suggest that in the regular population, in the standard population, that one is superior to the other when it comes to long-term effectiveness. They all have been performing in the real world quite similarly. I think that also goes to show what is available in your area. I mean, we often say the best vaccine is the one that's available to you, and we've made it very clear that the mRNA vaccines and Novavax are the leaders in that sense. And so I would not encourage anybody, especially during active outbreaks or during a season where they should get vaccinated, to shop around to find a specific brand because they think one is superior than the other. We just don't have data to justify that decision. We certainly don't tell people to do that with flu vaccines, and that's definitely what's happening with COVID as well.
Thank you. This question, I want to acknowledge this question. The question is about, are MECFS patients considered to have weakened immune system? I think Dr. Hopper have answered that they do have immune system dysfunction. But in case the speakers have anything to add, I want to pause briefly before I move on.
I mean, the end result is that it's a weakened immune system. You're more likely to get an infection because of the immune dysregulation. So yes.
Thank you. So we do see a raised hand. I want to acknowledge that, but I do need to prioritize people who have pre-submitted question earlier. So I want to go back to a question that has to do with the antihistamine already. I believe it was partially answered about the effectiveness of antihistamine and when they receive the COVID boosters. So I think, Dr. Hopper, you mentioned that this can still be a way that some provider will recommend. Do any of the speakers see any additional data or research that indicate one way or the other regarding the use of antihistamines?
I didn't see any data. What I found was an article that a mastocytosis society had recommended for people with mastocytosis. And so I guess my point of that is that it's not just unheard of. There was another group that had recommended it for people with mast cell activation syndrome, and they were recommending it just a dose before their vaccine. And like I said, with my patients, I mean, most of my patients, quite honestly, have MCAS, and so they're probably on an H1 and H2 blocker already. I just want to make sure they aren't missing. Sometimes we forget doses of medicine. I want to make sure you're getting your dose before you go. And again, I tell people it's, kind of like you're going to exert yourself. So one, you're exerting yourself depending on how severe you are. If you're going to the clinic or you're going somewhere to get a vaccine, for some people that trip is exerting themselves. So pre-rest, and then afterward rest. Again, it's an exertion. Even if maybe you do go to the store every day and that's not, if you're mild, maybe that's not such an exertion for you, but still getting the vaccine and stimulating your immune system is an exertion, so treat it as such.
Thank you. And Ms. Rivera, anything else you want to add?
No, the answer was perfect.
Okay, thank you. And the question, I think this question that I echo was does they look at people with ME? So it's not clear which study Katie refers to, but I do want to mention that sometimes when they test the new vaccines, they may not test those vaccines on people who have complications. But I want to let our speaker to elaborate other dimension for this question. Do you think those study tested vaccines look at people with ME when they before they launch it?
I'm not sure I understand the question. Are they asking if patients with ME are included in the study?
Yes.
That's what I read.
Okay, I don't know. I'm sure that there may be people who have ME that are included, but I don't know that it's identified. I haven't seen any that were.
Not in the original studies. There perhaps might be them now, especially in the context of creating, updated vaccines to understand what the impact is on populations a population like this that is sadly growing, but not in the original studies.
I think it would be great if they were. I did see where there was a study going on currently on patients who specifically had neurological complications or an adverse event after the vaccine was given, at least temporally. And so they're doing research on that. And I read an interview of the person who was conducting the research, and they were posed the question about patients with ME/CFS, and she seemed interested and talked about maybe going further with that. But that's just an interview I read. It wasn't anything official or that was ongoing at this point. But people are hearing about it. People in that world are hearing about patients with ME/CFS and long COVID, and hopefully we'll focus some of the research on that.
Thank you. And there's another popular vote. I think it's more like a statement saying that I hope that they don't go to making all vaccines combined, flu and COVID, since those of us who have a tough time after a vaccine, which means increased symptoms, will need to continue to get them separately. So could you comment on these, our speaker, to see the benefit and risk for combined versus separate vaccines?
Yes, this is a very good point. And I don't think that the movement to creating a combo vaccine is to replace the individual vaccines. It's for those who would benefit from having both at the same time. A lot of people did, vaccinate with both at the same time, but it is also recommended for folks who have a harder time and have setbacks or adverse events after an individual vaccine to space them out. And so because of those people who are indicated in that sense to have them separated, they will not, the movement is not to standardize this. It is an effort for those who are already having co-administration to make it easier and just have one injection, but it's certainly not a movement to replace all vaccines for combo.
Dr. Hoppers, do you have anything you want to add?
No, that was great.
Thank you. So this also partially answers some other question that's of popular vote. Another question I want to ask is more specific about lipid nanoparticles, which our audience said that it has been shown to leave the injection site throughout the body, including brain, and are known inflammagens. Are these appropriate for persons with MCAS?
Well,
again,
it's the excipients, right, that are usually the problem for patients with MCAS, or oftentimes are the problem for patients with MCAS. And what one person responds to is not what another person responds to. So for some people, that might be a problem. Again, if you are being treated for your MCAS, that can be optimized. And the Novavax is going to have less of those, and so that's not going to be maybe as much of a problem for you. Also, I lost my train of thought there. Hold on just a second. getting COVID, again, I keep going back to this, but getting COVID can activate your MCAS as well. So again, a COVID infection is also problematic. So again, trying to prevent harm. And I'm not trying to, insist that someone get a COVID vaccine, but at the same time, getting COVID is going to usually be worse for you than the excipient in the vaccine.
Thank you. And Ms. Rivera, anything else you want to add?
No, that's great.
Thank you. And another question I want to read out, because this does bring up the concept of weighing the risk and benefit, because we're dealing with things that both have risk, but which bear higher risk, which bears lower risk. So this question comes from Aaron. Since I have MCAS that is triggered by most pharmaceuticals, this MCAS came about after my first COVID injections. Is the COVID vaccine worth the risk of MCAS being triggered and or worsened? So this directly touch upon that many of the medical treatment bear some risk, but I want to invite the speaker to comment on how do you work with people around you to walk through the process to weigh the risk, which is higher, which is lower?
Well, one would say that if the vaccine, if you didn't have MCAS before the vaccine, you had the vaccine, now you have MCAS, something was going to, you had that propensity in the first place to have MCAS. Something was eventually going to trigger MCAS. It probably already was, actually. Again, I've seen COVID. Almost all of my patients with long COVID struggle with MCAS. So again, having the COVID infection triggered an MCAS reaction. So again, when you're looking at risk benefit, to me, so much of the time it is a risk benefit, right? And for patients with ME/CFS, it's different. It's not the same as the general population. I understand you're looking at it and thinking, okay, which is riskier for me? If you're a patient who's homebound, who's bedbound, maybe it's less risky. But if you're a patient who's in the public, or is exposed to more than just a couple of people, it's more risky. It just depends. And really, there's no way to know. There's no way that I can tell you 100% it's better for you to get the vaccine or not get the vaccine. That's just, I can't. I don't know. But in general, the odds are in your favor to be vaccinated.
And Ms. Rivera, anything else you want to add?
Yeah, I mean, I want to recognize how extraordinarily difficult this is, and risk benefits are not black and white. It is a spectrum of infinite shades of gray. I feel like an epidemiologist's favorite answer to questions like this is it depends. Depends on your age group. It depends on your comorbidities. It depends on other life events that might be happening, pregnancy, if you're advanced age or other illnesses that might be happening. It really depends. If reducing exposure and reducing infection is exceptionally easy for a person based on where they live and based on their exposure to other folks, I would say that definitely needs to be a factor in the risk calculus. I could never say that vaccination is not worth it unless there is a specific contraindication, because overall the benefits do outweigh the risks in vaccination in general. But again, it's not black and white when it comes to people who have other conditions to consider. It is truly case by case in the sense, and I think priority conversation with your provider.
Thank you. And I want to take the opportunity to apologize to our audience who are raising their hands. Due to the time constraint and the many questions we have in the queue in the regional channel we share with the audience, I'm afraid I cannot take the questions that from audience who raise their hand who might want to speak on the webinar. So I apologize due to the time constraint in that sense. But I will keep on pick up the popular questions in the Q&A so that we can use the time efficiently to answer as many questions as we can. So I do want to also comment on the so-called risk and benefit. Many of the studies that have been done were on the population basis. That means intervention or prevention can work for the majority of the population. But however, in the era of precision medicine, we do know that there are times it doesn't work, or it can even have potentially some negative effect for a subset of the population. So as a researcher, I just have to mention about that's why this is a frontier. We know something works for the population, or sometimes we don't know fully why it doesn't work for a subpopulation and why it even generates some setback per se. So that's why research is needed. And with that, I want to also ask this question from the audience, that this has to do with the perception of the so-called, I believe it's almost like vaccine injury term we hear. There are people in the long COVID groups that got what they refer to as long vaccine. So this is part of questions. And the question goes, they got long COVID from the vaccine. This is not my comment, I'm reading out from the question. And they are more and more of them. The question is on thoughts on safety of the vaccine, please. I want to invite our speakers to comment on this question. And maybe Dr. Hoppers, would you kick off with this?
Okay. So, I mean, that's kind of the same question in a different form. I don't know numbers. I could not find those numbers, and I don't want to discount anything. You know, if a person tells me I had the vaccine 2 days later, this is how I felt, and I was perfectly fine beforehand, I'm not going to discount that. Again, in general, the odds are better for you if if the COVID vaccine did that, then it's very possible or likely that that COVID would do that to you as well. So which is better, a controlled environment or not a controlled environment with the infection? And again, I wish I had an answer, but if I tell you don't get the vaccine because you might get long vaccine or long COVID vaccine, then, what about the other group, much larger group who gets long COVID because they get COVID? Do you follow that? Does that make sense? It's just that, again, it's odds. It's like a gamble, which risk would you rather take? And to me, it's a better risk to get the vaccine. In addition, again, if you have, if you don't know, you don't know, but if you have MCAS, if you have ME/CFS, if you have long COVID, if you do those things we talked about, resting, considering it an exertion, making sure you're having a good day, not a bad day when you get your vaccine, those things can help as well.
Thank you. And Ms. Rivera, anything to add?
I would add, similar to what I said earlier, that we can't deny the existence of vaccine adverse events. They happen, which is why we record them, and it's something that helps us understand vaccine effectiveness data even more. I do worry about labeling it as long vaccine, because I think in the end, what we're dealing with in regards to post-vaccination symptoms is most likely an immune overreaction. And whether or not that triggered an existing long COVID infection or worsened a long COVID infection, that's one thing to consider. But vaccine adverse events do happen. And there, as you said earlier, there are risks in everything. There's no such thing as zero risk or 100% risks. We have to understand that there are, it's a spectrum, but this is why we need to continue to have more real world data, more, observational research on people's experiences post-vaccination. But, the overall data, the abundance of data still demonstrate that the benefits of vaccination outweigh even the risks of that.
Thank you. And I, unfortunately, we've come to our time. I personally feel so sad I couldn't go over all the questions, because we do want to serve our audience to the best we can. And But we really appreciate your attendance for today's webinar and also want to thank our speakers. So as projected on the screen, aside from joining our real-world data platform, we'd also like to share with you that if you'd like to see more educational webinar or support our research and advocacy effort, please consider supporting SOLVE, and we'll continue to deliver educational and research programming to support our community who are experiencing ME/CFS or long COVID or other similar conditions. So attendees of today's event will receive an email with a link to the recording of today's session, and we'll also post it on all our social media accounts. And after our event ends, we'll also send out a brief survey on your screen. Please consider waiting and taking a moment to share your feedback with us so we can improve our program in the future. Many thanks to Dr. Hoppers and Ms. Malaty Rivera, to everyone who attended today. So we look forward to seeing you in another event in the future. Thank you.